Good afternoon and welcome to today's conversation on outpatient physical therapy during the COVID-19 pandemic, a clinician discussion. We are super excited to have our speakers this afternoon to discuss not only the impact of COVID-19 on the outpatient services provided by physical therapists and physical therapy assistants, but how they have survived and served their constituents in light of the pandemic and the implemented, um, I would say, services as well as the precautions that are and guidelines that have been imposed on the nation at large. And so I'm first going to start by introducing our speakers. I'll start with Jonathan Greenwood, who's a board certified pediatric clinical specialist and director of the physical therapy and occupational therapy services at Boston Children's Hospital in Massachusetts. He's also certified in early intervention specialty and in neurodevelopmental treatment. Carrie Hall is a physical therapist and president and CEO of Movement Systems Physical Therapy in Seattle, Washington. She has authored a textbook, Therapeutic Exercise, Moving Towards Function, served as a faculty member at 3 major universities, and presented on the movement system. And we have Leslie J. Waltke. She is a physical therapist with a clinical mastery in oncology rehabilitation, specializing in musculoskeletal, cardiopulmonary, and functional deficits related to cancer. She is the cancer rehabilitation coordinator for Advocate Aurora Health in Wisconsin and is the founder of the Waltke Cancer Rehabilitation Academy, a consultancy that educates and builds powerhouse cancer rehab programs around the world. And Leslie, you'll have to correct me if I pronounced the Waltke incorrectly.
You nailed it.
Awesome.
Good work.
So I'm going to start with Carrie, and then I'll ask you to go next, Leslie, and then Jonathan. And I'd like each of you to take 2 to 4 minutes just to tell us a little bit about your practices, the patients that you serve, as well as how COVID has impacted your area, where the state and city that you're in, as well as your practice itself. Carrie?
Okay. Well, I own Movement Systems Physical Therapy, and we have 3 locations in the sort of greater Puget Sound area. One is right in the heart of Seattle on Lake Union, which is an amazing location for us. One is in a smaller community, Mercer Island, and another is in Gig Harbor, which is a little bit south of the city. And Movement Systems Physical Therapy is an outpatient, primarily musculoskeletal, though we see some neurologic conditions as well. And we see everything from 7-year-olds to 97-year-olds or beyond. And our practice is that each of the doctors of physical therapy spend 1-to-1 time with the patients for 60-minute sessions typically, and we do not use assistive personnel. So our whole sort of emphasis is on the diagnosis of the movement patterns that are contributing to the underlying condition or injury state, or even in the post-operative state, trying to really optimize their movement system. And we feel that takes that doctor of physical therapy to go through that level of analysis and that level of education and teaching with our patients. So we don't see a tremendous amount of post-op. We tend to see people who are battling, multiple regional chronic sort of conditions, and have really not done well in other models and really need that level of specificity. And so we also believe that our patients are never discharged. that
Thank
our
you.
patients we are primary care for musculoskeletal, and that we are their physical therapist, and that when they have a problem complaint, to call us right away and get in so that we can manage it quickly and get them on their way and back into their healthy lifestyle. So as far as, as you all probably know, Seattle was the epicenter at one time in the country. We were the first diagnosis of COVID. However, our Governor Inslee acted swiftly and worked very closely with public health officials and with the frontline providers to be able to develop really important strategies. We started the stay home on March 25th, and we have not lifted yet. And we were slated to lift on May 4th, but I think he's going to be extending it for at least another week. But he calls it a dial, that he's dialing things incrementally so that people can get back to work on a very incremental basis. We've done a fantastic job, and I'm on faculty at University of Washington, the other one, in Seattle. And what's surprising is, of all of the UW medical systems across the state, right now, as we speak, they're released last Friday. There were 82 cases in all of the systems, which was amazing to hear. They had prepared for 900. They took it down to 700. The highest number of cases they had at any one time was 122, and we're now down to 82. So we're in our second week of regression, which is amazing. So I feel very happy to be in the state of Washington and how it's been handled here. As far as my practice goes, of course, we've been hit pretty hard, understandably so. We see a combination of telehealth and in-person visits. And we actually are, because we're in this beautiful area, we actually take patients outside as well, which is another option for people. And we haven't really hit below 60% census. We're hovering between 60 to 50% census. So, and we hope to not drop below 50%. So that's where we are.
Thank you, Carrie. Leslie, how about yours?
And Carrie, I actually have a former patient of mine who is in the middle of chemotherapy for advanced breast cancer, who lives in Seattle, who lives literally a mile. She lives in Kirkland, a mile from the nursing home epicenter. She was actually interviewed by Time Magazine a month or so back. So they're doing a fantastic job out there under some horrific conditions. Mm-hmm. So I am from Milwaukee, Wisconsin. I work for Advocate Aurora Healthcare, which is, I believe, the 9th largest health system in the country. We have about 70,000 employees. I am the cancer rehabilitation coordinator for the Wisconsin side of our company in Aurora Physical Therapy. So I am in the clinic 50% of the time, and 100% of my patients have some type of cancer. And then the other 50% of my job, I am running the cancer rehab service line for the entire system. And we have, just on the Wisconsin side, we have 16 hospitals and 18 cancer centers. And so we have PTs, OTs, and speech pathologists in each of those centers, inpatient, outpatient, and home therapy, that have some advanced training in cancer rehab. So my job is then to keep everybody educated, to make sure that our patients are being integrated, that the rehab is being integrated fully into cancer care, which means a lot of educating of nurse practitioners and physicians and surgeons and medical oncologists, radiation oncologists, and so forth, nurse navigators, setting best practice, and making pathways and all that stuff. So I talk a lot, and absolutely love it. We are, from a state perspective, we are kind of at, hopefully, getting towards the end of our apex of our COVID cases at this point. So we're kind of at the height of it right now. From a system perspective, we have almost 1,000, almost 700 inpatients right now, but between all of our hospitals. And those numbers are, like I said, are fairly high at this point and hopefully coming down soon. And then from a practice standpoint, we are about 20 to 30% over the system of our normal volume. We have a fantastic rehabilitation program, and we have specialists in spine and neuro and peds and pelvic floor and oncology and Parkinson's. And so depending on the service area, some of those have been impacted more than others. So a lot of our orthotherapists that do postoperative stuff are kind of twiddling their thumbs right now and helping out in other areas. A lot of our PTs have been deployed to screening, helping with PPE protection, with people coming in and out of contamination zones. So it's been a really huge team effort, which we're all very proud of. So yeah, we're running at about 20 to 30% of volume and hoping to slowly, again, use that dial terminology, that we keep pushing the date back. Again, we're going to see more of our volume. Right now it's looking around May 18th. But again, it completely depends on the patient service market, where that particular clinic is, and a bunch of other factors that I'm assuming we'll talk about.
And Jonathan.
Great, thank you for having me. I'm the Director of Physical Therapy and Occupational Therapy Services at Boston Children's Hospital. We're a 404-bed acute care academic freestanding children's hospital in the city. And we also have satellite locations. So we have on-site at the hospital outpatient-based services, and then we have several satellite locations where we treat physical and occupational therapy as well. Our patient population is certainly a little bit different. The oldest patient we typically see is around 35. So we enter into the adult world, but we consider that really old in our population. But we treat, infants all the way up through. And so our patient population is what you might consider as a traditional outpatient pediatric community-based services, as well as a lot of specialty services where our therapists are working alongside physician specialists in certain particular areas and clinic visits, and being able to deliver care there, help make decisions on surgical options and other things. We do have a fairly large international population as well. So about 25% of our patients on the outpatient side are international. And as you can imagine, a lot of them left and got repatriated back home. And so that was a fair amount of our volume that left. In Massachusetts, the 16th of March was our kind of starting date for stopping elective surgeries. And so a lot of our post-op care volume also slowed at that point, both on the inpatient side as well as on the outpatient side of service delivery. And so we're, again, same as you, Leslie, is we're looking at the 18th right now as a getting back to whatever that new normal might look like in a several phased approach. But when we look at our service currently, we are down to seeing only urgent and time-sensitive, high-priority patients in our outpatient centers, and only 2 of our 4 locations are open right now. We did fully close a few of our satellite locations, which then we had to move several of our patients, and if they needed face-to-face visits, get them to an approximate location if we could. And we've also, we weren't really set up in Massachusetts from a virtual visit or telehealth standpoint for physical and occupational therapy. But with the emergency stay-at-home orders also came the ability to deliver some telehealth. And so we've stood that up rather quickly over the past several weeks and are currently running at about 20% of volume in our outpatient services. And our inpatient volume as well as not so much in OT, but in physical therapy has dropped because of those post-op patients.
Thank you so much, John, Leslie, and Carrie. We already have questions coming through. I do want to remind everyone, please submit your questions via the chat and we will filter through them as efficiently as we can. And if you have questions that are more specific, you are welcome to email the practice department at practice-dept@apta.org. And so without further ado, let's get started with some of the questions that are coming in. Shabna Tandon asked that she is a manual therapist and practicing in Maryland, and she wants to know, how to safely practice during the pandemic situation. So maybe two of you can respond to what are some of the specific guidelines and practices that you've implemented that you either already had but are making sure you do, or the new ones that you've had to implement since COVID has started?
In general, the people that we are seeing now in the midst of the full-blown COVID, our criteria are for outpatient physical therapy patients is that if the patient cannot remain independent without our assistance, we will see them. If the patient's pain level is risk of either hospitalizing them or sending them to the emergency department, we will see them. If they're a brand new ortho or a new surgical or a new neuro diagnosis, whether it's CVA or Parkinson's, or in my case, a cancer diagnosis, whether it's surgery, chemotherapy, radiation, we're going to see them at least to teach them, again, whether it's telephone, video visit, or in clinic, we will see them just to get them rolling. Now, from a manual therapy perspective, to go directly to this question, is many of my patients that are coming into the clinic because of pain, I'm doing manual therapy on. So I make sure that first the patient goes through all the screening, appropriate screening, there's physically distanced in the waiting room. And again, my cancer patients are already pros at all of this stuff. They know how to do this and they take it very seriously. So that's not really an issue for them. But what we do is, sterilize between visits, the plinth, the laundry. I will have the patient wash their hands before they come into the treatment area. I wash, I glove. I have goggles on and a mask. A patient's wearing a mask. And then I wash my hands and then I glove up. And then I'm very comfortable in that scenario, as long as I know my patient's not sick, doing manual therapy in that situation.
I have very little to add. I think that's pretty much the way that we're operating as well. I mean, we've taken away so many of the areas that can be contaminated. Just for example, if patients are using a pen, we have our jar of new pens and our old pens. So they're only taking a new pen. They can actually take it home with them if they want it. But we have everything as much as possible that is touchless for the patients. We're not letting them use our credit card readers anymore, that we're inputting their credit card information. So there's really little touched surfaces with the exception of the treatment table itself. Patients, again, wash their hands before the treatment. We do as well. I don't glove up. I feel that the washing of the hands, and I like to have the tactile input from my fingers, and that's just a personal preference.
Yep. Completely concur.
And so with the patients, they're wearing a mask, we're wearing a mask. As was said, we make sure, first of all, that the patient does not have a fever and that they are not feeling ill in any way, and nor does the provider of care. So we are not, bringing anybody into the clinic that has any symptoms whatsoever. But in the abundance of precaution, we're both wearing masks. We have our N95s on order. We have not received them yet, but all of our patients either come with a mask or we provide a cloth mask for them. And I also ask my patients that when I do move in closely to do the manual therapy, that at this moment, we're gonna not talk. Obviously, if they have, they want me to stop doing whatever I'm doing because they're uncomfortable, they can say something. But otherwise, we're going to refrain from talking. Then I'm going to step back and we'll talk through, whatever we need to talk through. So at that moment, we're not holding our breath, but we're really trying to, refrain from, having a big conversation at that time. So those would be the only other things that I would add. Obviously, disinfecting all surfaces goes without saying. Can't think of anything in addition, but we've been very successful. I would say the only other thing in terms of the screening of which patients are seen in person, I think that there are also the patients that, without that manual treatment, their condition will get worse. And that is one more risk-benefit analysis that the physical therapist has to go through with that patient, that if they will continue to get worse, they're not moving as much. Now they're risking comorbidity, for a different reason. They're risking their health for different reasons because they're not able to be as physically active. And in that situation, I feel that if they cannot get through it with exercise alone or through a telehealth visit, then that would warrant an in-person visit.
Thank you. John, did you want to add anything before I go to the next question?
Yeah, the only other thing that we're doing is, as an institution, we are screening all visitors as they enter every location. And so they are being asked health screening questions.
Yep.
And if they do have any positive symptoms, are being referred for testing. But every patient over the age of 2 per CDC guidelines are wearing a mask or being at least asked to wear a mask. And all employees are wearing a mask as well.
So, John, you said they're being referred for testing. Would that be on site or would they be sent somewhere else?
So a lot of our clinics, a lot of our clinics have on-site. We're starting on-site testing now, or they're being referred to a clinic that has that ability to swab and test. And we have a lot of our testing is now done in-house at Boston Children's, and so we're getting results back through our own labs.
And for the three of you, are any of you hearing or doing of physical therapists doing any of the testing or just screening?
Screening.
Just screening.
Thank you. So the next question looks like it's addressed to APTA as far as, is there any news on negotiations with CMS to approve PTs for telehealth in the facility outpatient centers? I guarantee that you will know the moment after I do, because we are sitting like waiting ducks for that moment. There is not a new expressed approval, but we have definitely put in for that as an association, as well as had members fill out the templates and write to their congressional leaders as well as CMS. So we're hopeful that that will be part of the next package that's put out.
Mm-hmm.
Amado Jose Mendoza said to the Puget sound therapists, when are you slated to go back and how will you work with your patients that have multiple variables affecting them? And how will you get them back in as they are chronic? He stated that they've been working mostly with patients who are more acute, but a lot of the crisis affected your region. So have you closed or stayed open the whole time? So,
yeah, it's a good question. No, we have stayed open the whole time. That was not an easy choice to make early on. You know, as you know, we all felt like the fire hose was at our face, and we had to make decisions. And even though our clinics stayed open, there were a few physical therapists within our practice that chose to not come in for in-person visits. So we have stayed open. We have been seeing patients that are acute and chronic. Obviously, our patients at the highest level of risk, we have kept as much as possible in telehealth. We have had a few in-home visits that we've provided to patients. Let's say they just timed it just right and they had their total hip replacement right when this all hit, and the telehealth's just not cutting it, but they don't feel comfortable coming into the clinic. So we've actually had some patients, some therapists do in-home visits with the proper PPE and disinfecting and so forth. In the sense of what there really isn't anything that we're going to be doing differently. We will probably be more strict on temperature taking and more strict on screening of patients as they enter the clinic. We will be kind of staggering our shifts so that we don't have as many people, even though we are pretty low census because of our one-to-one approach. We're still going to stagger our schedules so that we even have that much more physical distancing. I would say one more thing for me. I have a few patients that are high risk that really needed the in-person. So I have come in on a Saturday to see them when it's just the two of us in the clinic by ourselves, so that they felt sort of even more safe, that extra level of safety, that it was just the two of us in the clinic. And we've been able to do that for some of our patients.
Just to piggyback on the safety piece, it can be very intimidating to come into a hospital. I'm sure John can agree with that for patients, because there's the white buildings, there's everybody in scary stuff and the screening questions. But honestly, patients, I will call them on the phone beforehand. They're most likely safer or less risk in our clinic or at our hospital than they are at the grocery store. Mm-hmm. And once they frame it in context, they're like, "Oh yeah, you're probably right." Mm-hmm. So, but it can be intimidating, versus an small outpatient center versus this massive hospital. It can be intimidating for patients the first time they come in, but we walk them through it, and again, the risk is quite low compared to something out in the general public.
Mm-hmm.
So I want to follow up with this question, and John, I want to make sure you answer this too, since you work with the pediatric population and have minors. One, how have you stayed healthy as clinicians? What measures are you taking for yourselves? And two, how are you handling patients who have to come in, or at least to the session, with an advocate or some other member of their family or friends?
Yeah, thank you for the question. I'll hit number 2 first and say that, as an organization, we've developed a visitor policy, and the visitor policy is both for our inpatient and our outpatient services. And so we allow the patient with 2 adult caregivers to be able to be present during a session. We're asking for nobody under the age of 18, so no siblings or cousins or friends coming with them to their sessions. And so we've had a lot of success with that. And where we found it, where we found places that we need to make exception, we take it on an individual basis. So that policy has been helpful. I know there's some other institutions that have a no visitor policy, but really in the essence of family-centered care and pediatrics specifically, we've maintained that 2 adult visitor policy, and it's worked out pretty well. In terms of keeping safe and healthy, I think there's a bit of self-care, I think, that we've been trying to encourage our therapists to take. It's a lot more work when you're thinking all day long about gowning and gloving and masking and, did I disinfect everything? It's just a lot more cognitive memory that's going on all the time. And so we are making sure that we hold open huddles every day with our staff for open communication. Ask any question you'd like. We'll work to get an answer together. We've had great support from our leadership, where they've put in place some other, emotional health supports through our HR department and other places where therapists can access free to make sure that they're taking care of themselves. And then again, it's hand hygiene, and it's cross-checking and making sure your peer that's sitting next to you is following the same standards that you are, and just saying, asking how they're doing, and making sure that everybody's following those same standards.
Leslie?
I would echo what John has said. I think extraordinary times requires extraordinary care and extraordinary caregivers. And again, you can see people, PTs that work under leadership that is not particularly brilliant and how they struggle. And then I'm in a situation where our leadership is just fantastic. So even though it is difficult and it is completely exhausting, especially the first couple of weeks, the amount of learning and things would change from, every 4 hours, that what you knew was now not even relevant anymore. So even though you're 50% less busy, you come home just completely exhausted. So I think mitigating burnout is really important. So when you're blessed with leadership or colleagues that can check in on you or support you with human resources and free resources, and our system has giving hazard pay to physicians and nurses and even PTs, OTs that are literally in the front line working with COVID patients. Just to feel supported is so important. And I think you don't necessarily need a leader to do that, but just checking in on each other and making sure that we smile every once in a while, and keeping physically active. Again, it is so hard to not, when none of us are moving as much as we used to. Again, it's all about taking care of each other and communicating and knowing this is going to be a long grind and persistence. Strength, I work with cancer survivor triathletes, and I say strength and speed will not get you to the finish line. Persistence will get you to the finish line, and that's kind of what I keep preaching to my colleagues and my patients, because this is going to be a long grind. So we have to take care of ourselves. Self-care is really important.
Carrie, did you want to add anything?
Yeah, I heard this great quote at the beginning of all this, and it was, nobody ever advises sprinting the first mile of a marathon. And that's what we were asked to do. And so those first, particularly a couple of weeks, was a huge sprint. And that was long days, for, I, as the owner of the company, it was long days to make sure that we had all of the policies in place, to keep our staff and our patients safe, everything communicated, all the messaging was out there. What was going to take us, a half a year, we set up our telehealth in 1 week's time. And, we got our telehealth up and running even before the stay home mandate was put in place. And that was sort of transformative for us. And that was a lot of work. That was that sprint. But things continue to change. And so we have to stay just, on top of it, ahead of the curve. But I would say the only thing I would add, aside from obviously our own self-care and our using our relationships with our colleagues and our family and our friends to help keep us supported, is also our patients. I was joking the other day that, and please don't take this the wrong way, but the COVID-19 could also be the 19 pounds that we're all going to gain from all of the treats that our patients keep bringing to us, the donuts and the cookies, because they're all baking, could be stress baking, and they don't want to eat it, so they bring it into us. And so we're like, we just feel this love from our patients constantly. And I think that keeps us going, whether you're in a telehealth visit or you're in an in-person visit. The patients are so grateful that we are still here from them. And that I think keeps us going.
Thank you. I have two questions. The first of which I'm going to take from Jen Corbill, which will be for you, John, and the second of which will be for Leslie and Carrie. And the first is, what specific precautions are you taking in the pediatric outpatient clinics? What have you put in place? And the second question would be with respect to your therapists on staff. How are you deciding who and when people should come into work, and are they being allowed to self-select as far as determining whether or not they feel comfortable coming into work and seeing patients? John, I'll start with you.
Yeah, so the first one is, again, it's communication from our leadership and taking a universal stand on a masking policy for all employees, as well as the wellness check that we talked about, that screening check that when they come into work physically. And then just diligent hand washing and making sure we have access to hand sanitizer throughout the clinics. From a sanitation of toys or therapy tools and things of that nature, it's really single. We moved a lot of single patient use, and then it's out of service until it's disinfected. That's for all equipment more diligently than we ever have before. So as Leslie was saying, I think we might have the cleanest clinic we've ever had, as we go through and disinfect things on such a regular basis. So that's, I think, the first piece. The second, with regards to, you'll have to remind me, I apologize. Oh, I think you're on mute, sorry.
Thanks, John. Yes, the first one was for you, and then the second one was for Leslie and Carrie, so you're good.
Oh, perfect.
All right. So staff and determination of who can come and can they self-select out or in?
Yeah, our approach was that all of our practitioners could make their own choices as to what they felt comfortable with. So we've had a huge variation in terms of, some therapists are fully comfortable with seeing patients in person, and others, really wanted to follow the stay home orders and stay home and provide only telehealth services. And so we have really allowed each practitioner to make that decision autonomously and supported them in those decisions. And that each practitioner is also making the decision with their patient, where the best delivery of care is. Is it in-person telehealth or waited out? And if they aren't providing in-person visits, then they will have them work with a person who is. And so therefore, everybody's census is a little bit lower. So we didn't say, okay, these 3 people are going to be doing inpatient or, in-person visits, and these are going to do telehealth. We let everybody manage their caseload, because that is their caseload. They are those individuals' physical therapists. So we allowed everybody to continue to treat their patients as best that they could, given the circumstances. So everybody is pretty much on partial unemployment. They're getting gap pay that help to shore up the difference between what they would be making if they were working full census and what they're, the other time that the unemployment is helping to support them. And I've personally not gotten the PPP loan yet. Keep waiting every day, keep looking, but I have not gotten it yet. So we're relying on, sort of partial unemployment to keep people economically whole.
So Leslie?
I work, again, kind of the opposite extreme of Carrie, where I work for a very, very, again, the 9th largest health system in the country. So a very healthy, robust system. So we have been able to continue to pay people full salary, whether they're able to see a full caseload or not. So we're very blessed there. So I think at the beginning, it was a little rattling for everybody, including a lot of the therapists. And what am I going to do? What are they going to make me do? But it really has fallen out to, again, depending on what kind of clinic you work in, whether it's in an urban inner city or high surgical volume, whether you're in a small community outpatient center, it's been impacted differently. But in general, we're taking the approach of, here's the stuff that needs to get done. Who can do, I mean, in general, PTs want to work, we want to help. So we've kind of taken the approach of, here's what needs to get done. And like Carrie said, you have to take care of your caseload. Look at all your patients. So our receptionists were fantastic at helping us. Here's your caseload. Here's the phone numbers. Check in with everybody. What do they need now? What can we do later? Who's appropriate for video visit? Who's appropriate for telehealth? And then saying, okay, these are the screening needs for our hospital. This is the screening needs for our hospice. These are the things that we as a cumulative company need. And some people say, you know what, I've got a parent at home with Alzheimer's. I can't do that. Or my kids are at home now. I can't. And other people say, you know what, I don't have kids at home and I'm good. So let me do this. And why don't you do that? So I think it just goes to the show the good nature of us as a professional community to help out where we can and do what we can and not get stressed out and finding ways to get everything need to get done that needs to get done.
Great, thank you. So it looks like we have a lot of questions to move through. And so I'll ask each of you to keep your responses to a minute or two so that we can get to as many as possible. They're super excited to have your input. I will say that there's multiple questions that are here about telehealth specifically, and that we have a ton of information on that on our website. So if it's specific to your clinic and not general to telehealth, you have the telehealth page at APTA, but you also can email the advocacy@apta.org for some of those questions as well. Let's move into some of your questions now. So there did ask if the APTA has specific public guidelines as opposed to just referring to the CDC guidelines, and whether or not we have outpatient recommendations and guidelines. There are both on the APTA website, and you could probably access those through the practice page and or the frequently asked questions. So if you start at the COVID-19 or coronavirus page of APTA, and then you'll now see guidelines that are specific to outpatient. This one says, what is happening with pediatric outpatient? My clients will not be able to wear a mask. Are therapists wearing gloves with the children? that would be for you, John.
Yeah, so we are, anybody over 2, we're offering a mask, certainly with certain populations with behavioral health issues, or there may be just a refusal to wear a mask. And as a pediatric facility and a family-centered care facility, we are not requiring the patient to come in with a mask if they're refusing to wear it. We will ask the caregivers, the parents, to please wear the mask as a visitor to our hospital. But the therapists are also wearing masks. At this point in time, the glove, and I'll even say gown and glove questioning does come up a lot. There is no hard and fast rule, different than any other practice that you're providing. So we're leaving it up to the clinicians as part of their normal practice, as long as they're using hand washing. We are starting to look at making sure there's added places for the kids to access hand washing as well, before and after the treatment, similar to what Leslie was saying, or Carrie, in terms of patients coming in and leaving. We want to make sure we're fostering that good hand hygiene of our kids as well when it's appropriate, or at least offering hand sanitizer to the caregiver to use with the children on the way out.
Thank you. So any of you can answer the next one. One, are any of you wearing any type of gowns for close touch to protect from the patient to patient? And secondarily, if you have someone who needs to be face down in a pillow for a while in treatment, are you still having the mask?
I can answer the second one. When we have our patients face down, we will cover the whole area on the table with a pillow slip and make a little hole so they can breathe. And at that moment, we tell them that they do not need to have their mask on, because we want them to be comfortable. I don't want them to feel like they can't breathe, because then they're tensing and not comfortable, and that's not going to bode well. And of course, that area, even with the pillow slip, is heavily disinfected after that treatment. And so we do not have them have their mask and be face down at the same time.
And I'm not wearing a gown, like a PPE gown per se, but I put a scrub jacket on over whatever I'm wearing that day, and it's typically scrubs in this scenario. And I just leave it in, I practice in one treatment booth, so I don't have to go out, and I just leave it, I take that on and off with each patient. And then, so when I leave the treatment booth, I'm not exposed to whatever may have been on that gown. And then when I get home, like most people, I take my clothing off in the garage, and I've learned not to have new clothes in the garage. I made that mistake the very first day, but not the second day. And everything just goes right into the washing machine. So to kind of mitigate any cross contamination of again, out of an abundance of precaution.
Thank you. So the next question I'm going to pull from Meg Friends from Samantha, is, do you have specific health screening protocol before a patient comes into the clinic each time? You all have spoken to that you do screening. So maybe if you can give the details of that screen or the screening questions that you're using.
So I can just speak that, ours are symptom-based. So they're going through the CDC symptoms of a patient who may present with a positive screen would be somebody who presents with those symptoms. It's not, we're asking for those who are sick, including employees. There have been some employees who have come more early on and arrived and then said yes to one of those symptoms and realized, maybe I shouldn't be at work today, and needed to go back home. And so it's more symptom checking when they're coming in. We're not yet doing temperature screens, which I know is present at some clinics around the country.
We are doing temperature screening, and I haven't been a screener in a couple weeks. But the questions are: do you currently have, or have in the last 7 days, have you had coughing or sneezing? Have you been around anybody known to have coronavirus or COVID-19 in the last week? I don't think they're asking, have you been out of the country in the last 14 days, because that's kind of now irrelevant. And have you had a fever in the last week? And then we're doing the temperature screening, I think, are the questions that are being asked now for incoming patients into our physical building spaces.
Right. I mean, the only thing I would add is the shortness of breath that's not attributed to, normal exertion, is one of the other symptoms. And for us, we are not mandatory taking temperatures of our patients, but if we ask them, do you know if you have a fever? And they're like, I don't know, then we'll use the infrared thermometer to check. And, so we have it there available, but we're not mandatory at this moment asking each patient to have a temperature check. But no coughing. Sneezing is not a symptom of COVID, but of course we don't want people actively sneezing in the clinic, and, feeling ill for any reason. On the provider side, we do ask that our providers take their temperature every morning. Right now, we're not logging that, but we ask them to just take that pause, take your temperature, just do a little check. We tend to, as providers, kind of, not pay as much attention to our own health. We're paying attention to everybody else's. So just take that moment to pause, make sure you are fever-free before you come into work.
So I have a couple of pediatric questions for you, John, from Catherine and Stacy. And one, are you servicing children under 2 years of age? And two, what is happening with the pediatrics outpatient as far as are the therapists wearing gloves?
So again, the therapist, it's really based on the procedure for glove wear. But yes, we are seeing patients under 2. Examples are, children with an early diagnosis, a young diagnosis of torticollis. We want to get in, do the evaluation, make sure they have a plan of care that they can then carry out virtually would be an example of that.
Do you find that it's unsafe for the therapist or the patient population if the child cannot wear a mask?
No, I think that we're still screening coming into these facilities, so we're pretty sure that we're catching most people with symptoms at the door. And we are also, we have an automated system that reminds them of appointments, and in there they're also being asked about their symptoms so they can cancel the day ahead even if they feel like they've been having symptoms. So there's a lot of checks and balances in place.
Carrie, I think you mentioned telehealth, and Leslie, you may have also. Jonathan had a question, and thanked you for the discussion. He's a PTA and a third-year DPT student. In regards to telehealth, how do you protect yourself if the patient falls at home? And mostly all outpatients, the screen is jumping around, have heavy, are really heavy on manual therapy, but in telehealth, do you find it beneficial for reaching the manual therapy goals?
Well, no, you can't provide manual therapy through telehealth, but it has been an actual, really great learning experience for PTs and patients alike. Some of the silver linings is that you get to actually see the patient in their home environment. So when you're teaching them an exercise in the clinic and you expect them to do it at home, you really don't know how they're setting it up. So when you see their actual setup at home, you're like, oh, no, that's not going to work. Or you're like, wow, that's brilliant that you figured it out to do it that way. And so you get to actually really work through, how they're doing these things in their own home environment. The other piece is that you have to rely a lot more on your verbal cueing and a lot more sensory motor perception on the patient's side, because you are using your powers of observation as the PT to observe their postural patterns or their movement patterns and providing them with cueing to feel what it is you want them to feel, which is actually is enlightening to the patient, because when you're in there with your hands all over them, that's a very different type of cueing than for you to verbally cueing them and have to internalize that sensory motor changes. So for a lot of the manual therapists, they find that this has actually been using movement and exercise and positioning has actually really opened up a lot for them through the use of telehealth. As far as preventing a patient from falling, obviously you'll take all the precautions that you can by not asking them to do things that would put them at fall risk, because you're not there to be able to support them. So it's really using your clinical judgment to make sure that you're not asking them to do something that would put them at risk for falling.
And the only thing I would have to add is just to make sure that if you're going to be assessing some type of balance or gait, that just make sure that there is another person in the house or right nearby that can say he can't do that, or just so you have it
yeah.
at hands.
Yeah. Mm-hmm.
Thank you. Jenna asked, how are you managing involvement of caregivers in the in-person visits in the pediatric setting? Are they still participating in sessions, or are you just working with the child to further minimize contact?
We are still having the families participate in sessions, and I think it's especially important because they're the ones now going home and helping carry over those home exercise programs, especially if we're supplementing our face-to-face visits with our virtual visits. And so we find using that time for not only direct one-on-one intervention, but also caregiver education is extremely important at this time, where we may have recommended at one point a post-op patient coming in 3 or 4 times a week. They might be coming in once or twice and then being seen virtually the other once or twice a week. And so by having the caregivers there to assist in the sessions gives them a better idea of what we're expecting when they do their virtual visits.
Thank you. And Cindy and Rebecca, your questions regarding the billings and the telehealth and insurance covering home therapies, I'd encourage you to send that question to the advocacy@apca.org and we can get you taken care of right away. Okay. And as well as Carrie, I'm going through the questions. For the future, if you are treating a patient with TMJ problems and usually perform manual therapy, joint moves, or soft tissue mobilization in the mouth, would the PT use a mask and shield or just a mask? Any suggestions?
Right. I mean, it's still not an aerosolized procedure, but you are in their airway. And I think in that situation, an N95 mask would be more appropriate than just a procedural mask. And, as Leslie said, perhaps goggles. We don't have the full screen masks in an outpatient setting, but if an N95 and goggles would probably provide enough precautionary measures at that point when you're working in someone's mouth and airway.
That speaks to Aaron's question, and any of you can add if you had something, which was, do you as outpatient PTs believe that an N95 mask will be your standard, or she believes that her clinic has surgical masks but not N95s?
I would love the N95 to be the standard, because that is truly the only way to protect you from giving it to somebody else or from getting it yourself. But they're just not accessible, and if they are, they're rightfully going to the PTs, OTs, and speech pathologists and nurses and physicians and everybody on the front line in the COVID rooms. So I would love it to, if it was available, but it's just not at this point.
I do think that they're becoming more available. We do have ours on order. We should probably be getting them in the next week, but it's not like you're going to be able to drop it in the trash at the end of the day. Right. It's going to be reused, and we're going to have proper, cleaning procedures. Donning and doffing procedures are super important as well to improve the effectiveness. But I do believe that it probably, again, depends on your setting. I mean, if you can keep physical distancing most of the time, then a procedural mask would be appropriate. But if you are within that 6-foot range of a patient, then I believe that the N95 should be the standard.
Thank you. Can any of you speak to postpartum for women and infant or toddler visits? Are we feeling it's more or less of an exposure risk to be in people's homes or in a clinic? That's from Kelsey.
I mean, we can control our environment in the clinic. I have 3 pelvic health therapists that are seeing, actually, that's one of the populations that really the census remained very high. Those people felt that it was critically important for them to continue to be seen, and they're seen in clinic, and we can control our environment. We know how clean and disinfected everything is, and so that would be our preference. However, for whatever reason the patient needs to be seen in home, we would also certainly, provide that to that patient.
Thank you. Victoria Jaramillo asked, they say the virus can be asymptomatic. How can we be sure patients are COVID-19 free?
Yeah, I think that's just that's going to be one of the uncertainties as we move forward. And I think, as an organization and as a state, and I'm sure every state is going to watch and see as we re-enter into the communities and get back to life as we know it, are we going to see a second spike? Are we going to look for increases in admissions and COVID positive? And, that's all going to be kind of the uncertainty of what we have to keep an eye out for.
Right. Beck, did somebody want to add?
I was just going to say that, if you remember back to the very beginning of this, before we knew that there was asymptomatic transmission, and we were just really doing the screenings, like if you have a fever, cough, shortness of breath, please don't come to your visit. Now we've got all of these additional measures in place, with the universal masking. Hopefully, again, providers will be in N95 masks in the not so distant future as a standard. So I think that, again, there is no such thing as zero risk. And for that patient to not receive their care in physical therapy might put them at higher risk for other health issues than to come in with a teeny tiny risk that somehow there will be transmission. So it's, again, that risk-benefit analysis that you have to provide on a case-by-case basis.
So we are entering the last 3 minutes or so of our talk. This has been a fantastic discussion. And I'm going to read one more question, and then I'll ask each of you to give some closing recommendations. Becky Barnell-Green-Guerin asked, what are you using to determine risk level for patients to recommend telehealth versus in-person visits? Are you using an algorithm?
Not me. We aren't. I think that, again, it's really a decision between the therapist and the patient together. And really kind of, again, using your professional clinical decision-making process and determining what is the best course of action for this particular person at this particular moment in time. Because it could change next week.
Right. Our key points are, if you're going to lose your independence, if you are in fear of, if you're going to end up in the emergency department or being hospitalized, or your pain is out of control, or there's going to be permanent disability because you're not getting treated, those are obvious people that we want in the clinic right now. So that's kind of the SBAR that we're using to get people in right now versus video visit.
So Dr. Leslie, there's a question specific to this, is considering the deconditioning low immunity, would you prefer a telehealth visit over in-person visit?
Again, I think it depends on where that patient falls on that. If they are in an emergency situation, if they're immune suppressed, we just take extra visits or extra precautions and get them in if they need to. But a lot of exercise and therapeutic exercise can be done over a video visit or even over the telephone. And again, what's nice is I am in an outpatient hospital PT department that's associated with a cancer center. So if we try to combine our visits, so it's only one exposure to the hospital, and minimizes PPE for the patient and for us. We have that advantage. So if they're there, I'm saying hightail it down the hallway and come see me as well.
All right. So it looks like we have about 30 seconds each for you to give your nuggets or jewels that you would recommend for people who are going to or already practicing in their outpatient settings. So start with you, John, and Carrie, and then go to Leslie.
Sure. I guess a couple of things I would say with regards to masking is that patients can no longer see our facial expressions. And so we instill a lot of confidence in our patients through our affect. And so be aware of that and make sure you're teeing up your patients for success. I think also, if those of you that have more pediatric specific questions, if you go to the Pediatric APTA website, they do have a COVID-19 discussion board. And so a lot of questions and answers specific to pediatrics can be posted there, and you'll get responses pretty quickly. And then I think the last nugget is just know that, we are resilient, and this is a dynamic process. And so as we all get back to whatever our new normal is, things may work and things may not, and that's okay. But we will certainly come out on the other end doing some new things in our clinical practice that maybe we never did before.
Very.
I'd actually like to put a little nod to the future, because there's going to be a lot to come as a result of COVID-19, and we need to be prepared. As physical therapists, we need to understand that our role is going to become even greater as we manage this sort of the post-intensive care syndrome, the ARDS, anything that's related to deconditioning from the quarantine, people's overzealous attempts to be healthy, which increases their injuries, the increase in chronic pain from people who have had long periods without their physical therapy, maybe increased fall risk for the elderly that have been self-quarantined. So we need to be there to provide the care to get our citizens back to a healthy physical lifestyle and back to self-efficacy and their well-being. So that we are going to be extremely important in the next phase as people re-enter. And I want, I'm like a zealot when it comes to physical therapists. So I'm so proud of our profession and how we've navigated this and how we will continue to move forward into the future.
And when it comes to clinics, deciding on when to open or when to more expand, I think, again, it's dependent on your patient service market and your current community spread specific to your location. And our decisions need to be data-driven, and we need to put patient and community and our own protection over profit. And communication is the key, and not only between us, but also with our referral providers, to let them know that we are here, what we're doing. So to restart those relationships, and communication is key. It's extraordinary times, but we provide extraordinary care.
This has been a riveting discussion, and clearly we did not probably get to half of the questions because there are so many. And as you noted, physical therapists and physical therapist assistants do want to help and do want to be part of mitigating COVID, but also taking care of our patients as we always have, and in knowing that might look different going forward. So I appreciate each and every one of your contributions to the discussion and your expertise. I wish you all well and continued health and strength as you continue to serve those of them around you. Thank you all for joining us today, and have a great rest of your week.
Thanks, everybody.
Thank you. Thank you.